So good morning, everyone. Thanks for joining us. My name is Bill Kormos. I'm the Education Director at the Stoeckle Center for Primary Care Innovation. And this is our Stoeckle Center seminar with our Alan Sandler Scholar in General Internal Medicine. I am sort of sure many of you were at yesterday's grand rounds and got to hear the introduction, but I'll repeat it for those that weren't. Dr. Sandler, as many people know, was a general internist here for decades in the internal medicine, and a fund established in his honor by his patients was created to help sort of bring in national leaders who can discuss issues around primary care that are of great importance to us. Today's topic is definitely in that area, the area of ambulatory patient safety. Our Sandler Scholar this year is Dr. Hardeep Singh, who is a professor of medicine at the Center for Innovation in Quality, Effectiveness, and Safety, based at the DeBakey VA Medical Center and Baylor College of Medicine in Houston. Yesterday, Dr. Singh, in addition to giving grand rounds, met with some of our primary care team leaders and quality and safety leaders in the ambulatory space. He visited virtually a few of our practices and also met with our medical house staff quality and safety committee and got to hear a little bit about what they're working on. The format of the Stoeckle Center seminar for the Sandler Scholar is to allow Dr. Singh to kind of go over some of his insights into the topic at hand of ambulatory safety, but then also reflect a little bit about what he heard yesterday during his visits and talking to us a little bit about what we're doing. So he's going to sort of give us some ideas. Once again, we use this as a way to try to get feedback about what we're doing from people who have expertise in this area. And then we always like to have a little bit of discussion with the audience. So as usual for Zoom, everyone's familiar now, throw questions or thoughts into the chat. And then at the time for discussion, which we hope to have a significant portion of this time for discussion, I will try to moderate the chat and sort of may ask you to unmute and ask your question, or I just may sort of summarize some of the questions for Dr. Singh. So as the discussion goes on, please throw those questions into chat. So it's great sort of privilege. And once again, as we were saying earlier, yesterday we thought was a very successful day. Really enjoyed having Dr. Singh join us. My privilege to introduce this year's Sandler Scholar in General Internal Medicine, Dr. Hardeep Singh.
Thanks, Bill. So I hope you can see my slides.
Yes, can you
Okay.
put it on full screen view?
Yeah, I just want to make sure. All right. Okay, excellent. Thank you, Bill, for the introduction, and thank you again for inviting me. I've had a very energizing day yesterday. It was really enlightening to sort of talk to folks and learn about what you're doing. What I wanted to do in the next about 15 minutes or so to sort of lay the groundwork for some discussion that we could do. I wanted to talk through some of the things that I was hearing, and then perhaps end with a few takeaways, some action steps, some really pragmatic tools and strategies that we could think about putting into practice as you progress in your work. So none of the challenges that I heard were anything new, and this would resonate with everybody here. I mean, primary care, as you know, we're having big competing demands. As you yourself said, COVID has been a big sort of influence in terms of what has or has not been done in the last year or so. We've seen in other settings as well that the resources and the time invested for safety improvement is always a challenge. This is also, I saw that yesterday. I saw instances where, people did talk about sort of lack of that team, distributed team. In fact, I was reflecting on this yesterday. The National Academy of Medicine report that came out in 2015 on improving diagnosis in healthcare, the number one recommendation it made was increase teamwork. Diagnosis is a team sport. We got to have better models of teamwork, which includes not just physicians, but specialists, nurses, patients, pathologists, radiologists, and that has not materialized very well over the years, and it's not anything unique that I saw here as well. We're all under time pressures. I think not just to sort of spend listening to patients, but also time to invest in quality and safety improvement work. There's no protected time that comes with our job to make improvements in safety and to sort of put into place some great evidence-based practices that are out there. So we need to sort of think about what to do with that. Not an easy answer here. I also saw, that there was a lot of data, like in the electronic health record, for instance. We've got tons of data that we're collecting, but we're still fairly information poor. So people talked about not having good systems to track information over time in what I call a information poor and a distributed work environment, where so we're fairly fragmented, whether it's between clinics or between inpatient and outpatient settings, et cetera. Also sort of saw some instances where, there could be better infrastructure for measurement of safety and better analytics. So working with folks in IT and informatics, trying to get data out of the EHR, to how to generate some good safety reports, that could be, a challenge at times. And then lastly, the value that people place on primary care work. And sometimes you would say respect, sometimes I get this. And I, by the way, was a full-time primary care doc before I became a researcher. And I can relate to almost everything I heard yesterday about, the accountability and the responsibility that comes sometimes with patient care. There's some diffusion amongst, primary care and specialty where, who's responsible? If I order the test, I should be the one responsible as a specialist, but sometimes specialists feel that, it should be primary care's responsibility. And oftentimes I hear primary care clinicians feel that they are getting additional work pushed down to them that could be done by somebody else, whether it's another clinician or whether it's another staff member who can handle and again support them in their what I call cognition and their work that they have to perform. So these are some of the challenges, and I must say none of these were any surprise to me. I've sort of talked to people in both VA and non-VA settings, and it's fairly consistent no matter which EMR you use and no matter which setting you practice in and how integrated it is. We've done some work in an integrated setting like the VA, and we still see quite a lot of challenges in information transfer, for instance. And so again, these are fairly common challenges across primary care. High-risk areas remain the same. I heard things about medications. Of course, the topic of mine and my sort of expertise is around diagnostic errors and some of these communication issues. And, people talked about that quite freely, about some of the things that you were seeing on the ground about, these things being common. Some people talked about it more than others. A lot of them related to things like follow-up of test results, follow-up of referrals. So I'm going to spend a little bit of time on those topics. But then there was a lot of things I want to give kudos to. I think there's a lot of highly motivated people who want to do the right thing. You have very highly engaged team members, and they were on the calls. I had people who were office staff and sort of nurse managers who seemed to be completely on top of things, and one person was tracking referrals. I mean, there's a lot of sort of highly motivated people doing the right thing. One thing really important for ambulatory safety is leadership interest. And clearly, by having sort of somebody like me talk to everybody on the ground, there's a lot of leadership interest to sort of do some transformation, if you will, to sort of think about how to improve safety. We're all sort of in what I say the Bronze Age of ambulatory care. safety, where we're still sort of learning how to do this better. There's just nobody coming and telling us as much as inpatient safety, right? So we're just different. So it takes time, and we still need to sort of rely a lot on what we call intrinsic motivation rather than some extrinsic pressure on improving safety, like, like a CMS or a Joint Commission requirement, for instance. So again, leadership interest is really key. I saw some sites had really good tracking procedures, and some sites were doing a lot of EHR practices better than others. I think I've heard some things where there was some in-basket management practices that were being done at some sites, which I thought would be a good idea to sort of translate across. And then the talk of safety nets came across, and I think Susan mentioned that you all are looking to build what we call sort of these safety nets where patients can be prevented from falling through the cracks of the healthcare system. So, make sure that the patients are having, we're closing the loop on patients, test results or referrals. And I think you all are working towards creating these safety nets. So that's a great initiative. I also saw I heard some talk about building peer support programs for, clinicians, which is really useful. And there are other, peer support programs could be of many kinds. And in some practices on the West Coast, for instance, they've had primary care clinicians just meet, together sort of in a practice facilitation style where you just talk about cases and uncertainty and fears. And I think it's a good idea to think about, how do you create a new model of peer support programs where you're not just talking about some bad event that happened, but also what are we dealing with? What are our fears? What are our uncertainties? Let me know about that patient who's bothering you, and sort of help your peers walk through that. And then there was some talk about collaborative care agreements, which we have done some in the VA between PCPs and specialists to address some of those ambiguities that I was talking about. In the VA, for instance, we've had consults that have been discontinued by specialists repeatedly because they say, well, primary care, you need to really do these tests before you send us these patients. And so we have found these pilot sort of collaborative care agreements useful. And I heard that, you've tried this program, and I think it would be a good idea to think about, how do you build that program further. And the opportunities are plenty, and just like with anywhere else, I think, and this would be true for any primary care practice in US and for every place I go or talk to. I mean, we really need to think about models after that, the typical 8 to 5. We're just going 8 to 5 patient care in primary care, and there's no protected time for safety improvement. So if I really want to improve, if I really want to put into place some good clinical practices or some tools or implement some strategies, where does that time come from? In addition to my usual clinical work. So 1:1 patient care is great, but sometimes I need to sort of think about my entire sort of patient population. How do I improve myself? How do I make sure that at a population-based level, I'm doing good with my panel? So thinking about those things, I think we need to think about how to build time for safety improvement. I heard a lot of talk about reporting. I think people have started to report. It was very encouraging to see some RL solutions and all these systems being used. But one of the things that I think obviously is true for your practice as well as everywhere else is, clinicians typically don't report. And they, it's usually nurses and pharmacists that report. So you get a lot of falls and medication errors, but you don't get a lot of things that are related to communication issues, test results, follow-up issues. So thinking about, how do you get clinicians to report? How do you build the local champions who can encourage others to, put reports in? So if you have missed a test result, for instance, how do you do that in a safe manner? And what we've been sort of thinking about this is, try to think about this as brief solicited reports from clinicians rather than the onerous reporting systems that we have. And so several health systems that I've worked with have built in fairly easy ways to collect very brief information from clinicians about what happened, maybe just the name of the patient and, what was their problem and when, and that's it. And then somebody else does the investigation. And then when somebody else does the investigation, feed that information back to the clinician from where that came from. And one of the health systems that I'm sort of talking to is not just doing it for, feeding it back to the clinicians, but figuring out at an aggregate level what's happening in these reports, and maybe crowdsourcing some of this information, letting other people know these things are happening, and then let them comment and put into place some improvement strategies from reporting. I think a big opportunity is, because we're collecting a lot of EHR data, it would be great to provide some analytic support to primary care. I would encourage meetings with your chief medical information officer, perhaps some other folks who do EHR data analytics, to see how we can build reports, not just the reports, the usual quality measures and the reports we get on our diabetes. I'm thinking, specifically safety related reports. And I gave some examples yesterday how we built electronic trigger algorithms where we identify patients falling through the cracks of the healthcare system, where, if somebody has a chest x-ray or a fit test, which is abnormal, but has not been followed up, how do you identify those patients within a certain length of time and build that safety net that could support the PCP? So, for instance, if we have a list of people who are falling through the cracks of the healthcare system, or potentially so, let's just not give that information through an email to the PCP. Let's build some robust tracking systems where, we've got additional people, and there's a very nice system called SureNet that Kaiser is using, where there are a team of people other than the primary care provider who actually do some of this tracking and close the loops through electronic surveillance strategies. So thinking about how to use the EHR data and closing the loops. The other thing I think would be good to cross-fertilize best practices. I heard some really cool things happening. I heard one person say that they have their scribes remind them when they don't do a differential diagnosis. I think that was really, really cool. I heard some places doing a really nice job with tracking. Some people were kind of thinking about EHR in basket strategies that I bet that could translate very well to others. In our work on studying the EHR in basket, we've actually found that even within the same health system, even within the same EHR, some places are using really good practices to deal with their EHR in basket, and others are not. So it'll be a good idea to sort of standardize some of these things across. And while we're sort of talking about standardization, it would be also good to sort of think about some standardization of policies and procedures in high-risk areas, such as referrals and test results. In the VA, for instance, we've had really good success with coming up with standards on, how long should it be before a patient should be notified of their test results at a maximum. So we came up with, with timelines. If it's a normal result, no action required, maybe we can take 2 weeks to notify somebody. But if it's something that's abnormal or clinically significant, I mean, not life-threatening, but clinically significant, such as LFTs are abnormal and you need to follow up, or the thyroid is 20 and you need to increase the synthroid, we give only up to 7 days. And of course, you need to come to an agreement for that. But it'll be good to think about policies and procedures, including things like who's responsible for that test that you just ordered, and making sure there's no ambiguity between, let's say, primary care and specialty. And then I'm going to talk about tools a little bit later, but also thinking about collaborative care and teamwork models. So there's a program called Team Steps, which is, AHRQ runs that program curriculum. Think about sort of implementing that in primary care as well. I think it would be a useful thing. So the final part I want to sort of talk about, so this is a paper that we just wrote in JAMA about a few months ago, where we described this roadmap of key milestones to advance ambulatory safety. And I'm not going to go through each one of these, but essentially we think about this as sort of 4-pronged approach. So there are things to do with advancing research and science. So if you want to start with this, the science box. There are things that we must do with, from sort of the patient perspective, including sort of how do we improve the patient-generated data for safety? How do we use that patient-generated data for safety? Are there ways to enhance the current instruments, for instance, CAPS and Press Ganey, where we can collect more safety information? We talk about policy issues. So we propose, for instance, in the bottom right, better educational models for the future generation, more interprofessional models. We propose sort of new frameworks for governance and oversight and accountability to support outpatient safety, which hasn't sort of happened as yet, including a National Patient Safety Center, which has been talked about for a while, but hasn't been implemented. But I want to spend some time in the final box, which is sort of more to do with practice and practice improvement. So my last few minutes, I'm just going to show you some examples of sort of the things that I see on the horizon that might be really useful. And then we can have some discussion. And I think I'm going to end in a couple of minutes just to give you examples of what I'm talking about here. So we're thinking about, we talked a lot about monitoring and measurement of safety, you using incident reports. So here's a report that we, put out for AHRQ, which gives you the types of methods and models and strategies that can be used to measure patient safety or, or diagnostic safety in any setting, and how they are useful. So I would encourage you to look at this report and see, where you want to learn from. You want to learn from some of your malpractice claims. Maybe an outpatient M&M, you want to create that model. Maybe you want to enhance your peer review processes. Of course, we talked about incident reports as well. Maybe you want to look at some high-risk areas. So maybe cancer, looking at some records for cancer, doing a deep dive, learning from, are we having delays in our care, looking at maybe the last 10 cancer patients that were diagnosed in practice X over the last year, and looking to see if there were any missed opportunities. Around a third of our patients that we've studied have missed opportunities in diagnosis in both colon cancer and lung cancer, for instance. There's also safety culture issues. So there were three things on that model that I just showed, and I'm just going to walk through quickly all three of them. So the second thing we showed was learning from safety culture data. So I think Susan let me know yesterday that you actually have access to the data on safety culture, some of the surveys that you all are sort of filling out. I think it's probably every year or every 2 years, but I believe it's every year now. And this one, this medical office culture survey that comes is going to have a new supplement coming out next year on diagnostic safety. So there'll be a really good opportunity to get data from the clinical practices around some of the high-risk areas we discussed. There's questions on that. I mean, I'm involved with pilot testing and for that, so I know it's not out yet, but it's essentially going to be covering a lot of the things that we talked about yesterday, including follow-up of test results and closing the loops and referrals. It'll be a really nice way to get a look broadly across the practices to see how you're doing, and maybe even comparing it year to year. And then finally, I'm going to leave you with some tools to think about. We talked about these yesterday, and I thought at least I'll show you a glimpse of some of these tools that are available. We really need to figure out how to put these tools into practice, because they will address a lot of the high-risk areas that we talked about yesterday. So AHRQ has this wonderful tool on improving office testing process. It's freely available. All the links are here. Feel free to share. There are ONC safer guides that we help develop, which are essentially self-assessment tools. They're not meant to be regulatory. They're focused on 9 risk areas, but essentially the one that I'm thinking most useful for the outpatient setting would be the one on communication and closing the loop on test results. That should be very useful. Again, freely available. And essentially, you would just do a self-assessment. The good thing about using these tools is some people have to get together and talk to each other about, what they are doing and what they are not doing. So it really gets you to think about talking to your informatics folks and your quality folks and administrative folks and the clinicians. Everybody works together. And so I think it's a very nice way to think about, how you want to use these tools. ECRI partnership has had many tools. One of them is focused on closing the loop. ECRI's been in the patient safety area for decades. Another one that they have, which may be useful, is sort of patient identification issues. And you could just look at this website to see, what other things that you might find useful. And then lastly, talk about referrals. This came up quite a bit yesterday. And we have seen, even within a fairly close system, such as the VA, about 6 to 7% of information gets lost to follow up between primary care and specialty care. And there are many reasons for that. But it is a high-risk area. And I want to show you this model that was actually developed for a report that was put together by CRICO, right there close to you, and IHI, on improving the referral process. And essentially it walks through each of these processes and gives you ideas as to how the referral process can be improved. And this report again is freely available from the IHI website. And David Ting, who some of you might be familiar with, was a co-chair with me on this panel. And it would be a nice sort of way to implement some of those practices. And then lastly, don't forget, this is not a US problem. This is a worldwide problem. WHO about 5 years ago came up with this very nice series, which is again, sort of just sitting on the shelf on primary care patient safety, and has lots of good strategies. Again, both practical strategies for practice, but also sort of policy level strategies, which may be useful for you to think about. And again, so lots of good things to do, and we just need to sort of have the time to get it done. So thank you. I want to stop here and look forward to questions and discussion.
Thank you so much, Dr. Singh, for that overview, the reflections on your visit with us yesterday, all those good resources. We will have the slides posted on the website so people can get some of those web addresses and things like that. Pat and Gavin, Susan's telling me, contact Pat and Gavin if you want the slides. I guess that's the best way to do it. So start throwing some things into the chat. We've got a few lined up already, but we're looking for people maybe to share some of their challenges or experiences, or maybe even best practices. I'll start, Hardeep, with something that came up yesterday. In the world of outpatient practice, you know, we're often kind of very isolated, kind of, it's just us in the room with the patient. You don't necessarily have the same dynamic you do on the inpatient setting, but sometimes we notice sort of something in a colleague and a peer where we might think, you know, is this a safety issue? Do we see something when we're maybe cross-covering a peer, or maybe a nurse sees something when they're working with a physician? It's often challenging to then sort of escalate that so that people know there's an issue, and kind of filing that safety report has a very high bar, it feels, and sort of almost difficult, you know, like a punitive type thing. What do you think sort of our best practices so that we can kind of educate each other and help each other when we see safety issues in the outpatient setting?
Yeah, I mean, I think this is a tough one, you know, calling out maybe potentially a colleague. Bill, but do you mean mostly in terms of sort of more interpersonal types of things, or do you think sort of more like safety issues with patients? So the fact that, you know, they clearly should have followed up on a test and
right,
you know,
so discovering,
you know,
cross-covering a patient, and you discover that there is a test result that was abnormal, that you see no follow-up done by your colleague, or, you know, perhaps your colleague prescribed a medication and you think, well, that could be, you know, sort of a safety issue for this patient.
Yeah, definitely. So, you know, I think here's where sort of the culture issues that I talked about, the safety culture issues, are so important. We actually did a survey across 4 different institutions, and we asked about the comfort level that people had in talking about different types of medical errors with in a private setting and as well as in a public setting. And you could see 2 patterns as far as for diagnostic errors. So the errors that were closer to the sort of the physician's heart, they were much more uncomfortable talking about their or somebody else's errors in both kinds of settings, both public and private settings, as compared to any other different type of error, so medication system error, because it was so personal, people were just very uncomfortable. But in one site, there was market difference that people were a lot more comfortable talking about these things in both public and private settings. And that was a site that had done the most amount of quality improvement and culture change over the last few years. And so I think the leadership in that, again, I can't sort of disclose the details, but the leadership in that facility essentially set the tone of this is okay, this is safe, please tell us because we want to learn and do better. Other people have caught on to this approach rather than calling it my error or my missed opportunity. Call it learning opportunities. So can we just collect learning opportunities? So in one study recently, a fellow just went around and asked people, in their, institution, can you report to me all your learning opportunities and tell me what you learned so that I can then sort of aggregate that data and present it and tell everybody else what's going on and paint a nice rosy picture of, how we can do better. So I think sort of building some champions, making it a safe zone by having a lot of peers sort of encouraging other peers to go talk about and make it sort of a learning experience, sort of changing it from I made an error to what can I learn from something I just did. So that's the way I would think. And again, I think leadership issues are really, really key here. Setting the tone is really important.
Great, great. Thank you. Karen Carlson had a question about the peer support. Go ahead, Karen.
Actually, I think Josh had a question. I don't know if he's still on, but I'm happy to yield to him.
No, go ahead, Karen.
If he is.
No, I specifically stepped over Josh.
Oh, okay. I did. All right, fine, good enough. Thank you so much. My head is spinning with so many wonderful things, and thank you for sharing your observations with us. I wanted to ask you a question about peer support, that aspect of things, and I wondered whether you in your travels have come across the use of ballant groups as a method of peer support that provides an opportunity for reflection among colleagues on the feelings as well as the thoughts that come up in caring for patients. It includes a systematic kind of very structured way of looking at what might the patient be feeling, what might the doctor be feeling, and what's going on in the relationship. And it gives a way of allowing us to have insights about each other in a space that's very deliberately constructed to be non-judgmental, confidential, not shaming. I wondered if you had encountered that in your travels.
Yeah, absolutely. I think I missed it because of internet. So what did you call them? Focus groups?
They're called ballant groups. They're named after a Hungarian husband-wife team who did this post-war in England, and they've been doing them for 50 years. They're done internationally. So ballant, B-A-L-L-A-N.
Got it. Okay, I did not know that name, but I have. In UCSF around the San Francisco Bay Area, they were doing it exactly the way you sort of framed it, where people would get together and share anything. And there was I think they would call it practice facilitation, but essentially there were groups very much like this. I'm happy to look for the paper. There's one paper on it. We worked with somebody else to have another paper which never got published, but essentially that's exactly what they were doing. They were talking about uncertainty. They were talking about fear. They were talking about difficult patients and what to do with it. They were talking about sort of burnout issues. The issue is, I don't think, so with the people running it, one of the problems they found was, getting everybody together and finding the time to do it and the resources to sort of get people together. So I really think that's a great idea. And yes, few people. I believe that person was working with some folks on the East Coast as well to try to replicate the same model, but I'll get you details and I'll
okay, that's great. Thank you. Hey, we have Zoom now.
Yeah, I know.
Thanks.
All right, Dr. Metley, you're up.
Thanks. And thanks again, Hardeep, for coming. And I really believe like accelerating our thinking and work in this space. To pick up on something that Bill said, it really does feel in the ambulatory setting, this kind of sense of individual isolated little practices, kind of in a more nostalgic view compared to the inpatient setting, and I think has made this a much harder thing to tackle it. But there really is a way to move forward. I sort of want to pick up on something that we've all experienced now in the last year that has only, in my sense, accelerated my worry, which is the move to virtual care and what that's going to mean for all of this. So just to quote the famous Rumsfeld quote, there are the known knowns, there are the known unknowns, and then there are unknown unknowns. And I think there are a lot of unknown unknowns about what's going on with care, virtually speaking, on a video visit, because now nobody is seeing the patient except just the one provider on the screen. And there's not even there's no nurse check-in, there's nothing going on in this sense. So how are you guys starting to think about video care in this space? I worry how much cues and information we're not getting that are so vital for making diagnostic decisions and therapeutic decisions that we don't even know we're missing them in some sense because we're not there, or they're not here. It seems like we'll move backwards, obviously, I think, hopefully, to more of the traditional ways of taking care of patients, but we won't go all the way back, certainly. And so
yeah, Josh,
about virtual care.
Yeah, no, great question. We've been sort of exploring this area. We actually submitted a AHRQ supplement to study telemedicine-induced, what we call now telediagnosis-induced errors. It didn't get funded, so we put in another grant. So let's see how that goes. But essentially, we have been hearing anecdotes about what's going on. And not just in situations where there's, the history and the physical and the uncertainty, and I couldn't examine that patient because they had abdominal pain, and so therefore I may have missed the diagnosis. We've seen, diagnostic error even when you have objective data sent across. So in one case, somebody had a rash, and 3 different dermatologists made 3 different diagnoses, even though they had objective data to look at the rash, not just this, there's diffuse patient symptoms that nobody, seems to put together. Really a high-risk area. And, you could stimulate, I'm just sort of thinking, building sort of some of the earlier comments on trying to learn from what's going on. Could you stimulate some reporting in this area? So just tell people, if you had a telediagnosis or telemedicine-induced safety events, can you send this to the special line? I was giving an example yesterday where some health systems are using either apps or like a Tiger Text or an Epic in Basket to a specific diagnosis-related person for specific diagnosis-related issues that you can sort of stimulate and sort of enhance the learning. A new area, definitely.
Great. Susan just threw in the chat something about IHI working on this as well with some of our locally known people. Anne had a kind of question about sort of places that have successfully developed a team system to kind of counteract some of what we were talking about. Go ahead, Anne. You want to ask your question?
I can't.
We can hear you.
We can hear you.
Oh, you can hear me? Oh, okay. I have technical difficulties on my computer. No, I was just trying to imagine a world where everybody's looking out for each other, and there's just this wonderful team where you have people kind of looking at all of the results, double checking, double checking everything, and then, letting people know. Or also, when my nurse practitioners see a patient, they're like, well, what about this? What about that? And having that, I think somebody mentioned yesterday, curiosity, having that wonderful, collaborative, inquisitive approach to how we navigate complex questions or complex patient issues. So I don't know who's doing it. I'd love to learn from other places and try to build that in.
Let me know if anybody's doing it. I just think that this is such an important area. I don't know of any place specifically doing it well. I think even the best of places are, I would say, sort of struggling for the basics. So a long time ago, we used to think that improving communication of test results and closing the loop on test results was the most fertile area where we could, fix the problem in no time. And we realize it's such a complex area that intersects with not just the technology and the electronic record that's transmitting these results, but the workflow and the teamwork and the organizational policy and sort of the regulatory environment that we're in. Almost anything that we touch is essentially in that area. So we had this great idea that I hope there's some nurses in here hearing me out as well, that we thought, maybe some of the nurses would help us prevent some of the, follow-ups, because I can get my team to sort of help me, make sure that that result is not missed, and I have, not sort of overlooked something. But when we talk to the nurses, they say, look, I mean, we got different, sort of divergent opinions. We'll say, well, some of this doesn't come under our, scope of work. But the others were like, we're already doing so many other things that we'll have to drop something else and, participate with you. So what I thought yesterday was, and what I think needs to happen is newer models of care, where we're just going to need to sort of think about more the way primary care is structured and paid for. That's what's going to, I think medical home was supposed to do that, but I don't think it has. Even in the VA, we spent billions into primary care medical home models, but we're still missing test results. We're not able to get all the nurses engaged in follow-up for various reasons. And so even though the National Academy of Medicine says, great to have interprofessional models where, you would have somebody support you as a team, but to implement those models has been really, really hard. And that's what the challenge is. It's nice and rosy to talk about it. It feels really good, but implementation of every single one of those things people want to talk about has been really challenging. And ultimately it comes down to, we just don't have good policies and structures and regulatory environment to enable that. So I'm a little less optimistic about who's doing it really well, because I just haven't seen it yet. But do let me know if you do.
Okay, good. So everyone continue throwing things in the chat. It looks good, and people are sort of throwing some things in for discussion as well. Susan, I believe you were waiting to ask a question.
Yeah, so I have two questions, or two things that you shared with us yesterday that I'd love for you to share with everyone today. And one is the story you told about house staff doing chart reviews, and how after doing chart reviews, their own charting really improved, because I think that really relates to kind of part of what we're talking about right now. And the other thing, which I think is something that I worry a lot about, and we heard real examples yesterday of diagnostic error issues around this, is what you shared with us about the policy that the VA created, that whatever doctor ordered a test, they own it. And then and it doesn't get buried in the primary care consult note or whatever.
Yeah, so important. And I see actually there's a question by Jason on similar lines, so I'll try to address that as well. So essentially, for those of you, I think I was in a small group, so I'll give a little background. About 12 to 14 years ago, when we started doing all these chart reviews to look for diagnostic errors, we had to train clinicians to go look for all the clinical information. So we hired residents and fellows to do it. And at that time, we came up with some questions that they would look at the chart and see, was there a missed opportunity? Was there a delay in care? Did something go wrong? And then we trained a bunch of people. So 2 residents came and told us after several months of doing it separately that their attendings and their peers had started telling them, asking them what was different that they were doing, because their documentation of clinical reasoning and differential diagnosis in their notes got so much better over time. And they told us that they thought it was related to being trained on how to look at a record and learn from it. They were not necessarily being told to learn from it. They were told to go look for errors and mistakes and opportunities for improvement, as we put it. And so we developed more of a structured instrument that I showed yesterday called the SAFER-DX instrument, where it cognitively deconstructs the diagnostic process where you can look at your own note or somebody else's note about a patient, where you think there may have been something go wrong, or you think there may be a missed opportunity or a learning opportunity. And we found that really useful. What we're trying to do now is to come up with some sort of a little program where clinicians could look at either their own record or somebody else's record in a much more structured fashion, and not any record. I think the yield is for high risk records. So I would say, somebody maybe who presents to primary care, but then gets unexpectedly admitted in a week or so. I would look at those types of records. So stay tuned for that, and we think we'll have that program done in about 6 months to a year. We're working with AHRQ on that. The second issue that Susan mentioned is an interesting one, where we found that there was this, the risk of loss of follow-up of an abnormal test doubled when two clinicians got the notifications in their EHR in basket. So if the specialist ordered the test and I'm the PCP, both got the notifications, and the test results was more likely to be missed because I would think the specialist is going to do follow-up, and the specialist thinks I'm going to do the follow-up because I'm PCP. I'm supposed to do everything, right? And so when we found that there was no local policy in writing which said that ordering clinician is responsible for follow-up of the test results. So we not only changed the local policy back in 2010 in the Houston VA, but then in 2014, I believe, we changed the national policy in the VA, where it's clearly documented that if you're the ordering clinician, you are responsible unless you delegate that responsibility in writing to somebody else, and that person sort of acknowledges that responsibility. It led to a huge sort of pushback from some of the specialists saying, primary care should be doing all the communication of results to patients. We don't have the time or resources, but we've had very sort of strict implementation, and because of the VA, it's a directive means they're pretty serious about it. I would encourage all institutions to come up with policies. And in fact, I told Susan that I'm going to send her the VA policy, and then you can see how useful and applicable it is. We've had several health systems in the East Coast try to adapt the VA policy on notification of test results. So it's been an interesting experience, but it makes sure that people are accountable for what they do.
Oh, Hardy, one thing, many of our ambulatory practices do have trainees, many residents. We have medical students as well, but probably more applicable to the residents. Are there different things we should be thinking about? Sort of, you met some of our residents who are interested in quality safety yesterday, but the supervision versus the autonomy is different in the outpatient setting. So for example, those test results and referrals that you're describing, I have a much lower chance of kind of knowing about those with my trainees. At least, some are not copied to me as the preceptor, others are. While on the inpatient setting, the next morning on rounds, I always hear about everything that happened. And so as far as that sort of asynchronous care that is so much part of ambulatory care is harder to supervise, do you think there are best practices, or do you think there are ways that the electronic medical record without killing my in-basket could be handled?
Yeah, the key term is killing your in-basket. Somebody's got to be notified, right? So if it's not you, it's somebody else. That's a problem. It's hard to sort of give work away and to pull work away. So one of the health systems, what they did was they assigned a specific dedicated attending to the resident throughout their 3-year experience. And anything that the resident didn't follow up within a matter of, I think, 7 or 14 days in their in-basket got automatically escalated to the supervising attending. It requires a lot of, IT sort of, background. I'm not sure, this is in the VA, obviously. I'm maybe sure there's ways to do it in Epic. The issue is there's just so much work in the in-basket that somebody's going to have to do something. So we have to take something away from the in-basket in order to make sure that you get the signal and you don't feel that it's an additional workload for you. So that's where, what can we give what can somebody else do for me in terms of, a support staff, or could our nursing staff help us with some of those messages that we don't necessarily need to see? That came out yesterday very strongly, that people felt that there are in-basket things that could be taken away. And so I told Susan, we've talked to several people about the in-basket, come up with some strategies, how you can cut the load, including getting some more of what I would call a protected time if my in-basket is falling behind. There are institutions who look at your in-basket and, send people out to help you if the in-basket is not being managed appropriately or correctly. I think there's a lot of system types of things that can be done to support the clinicians to make the in-basket load better.
I thought it was
the point is, go ahead.
I don't think so.
Oh, I think it was just background noise. Yeah, so somebody has to see that result, essentially. That's no matter where, but somebody has to follow up. If it's not the resident, then somebody else.
Great. Yeah, I think it's one of the things I think that we do struggle with, and sort of just monitoring sort of our own in-basket volume and keeping it. And then, we often have our trainees who are, we attach to their in-baskets and kind of look in there and see what's going on. I would say personally, for the way I practice it, it's more sort of a gestalt view. I look to see, like, how does their in-basket look? Does it look like they're keeping on top of it versus the individual results that are coming back, unless it's something in particular that was, thought to be high risk. But so much of the results in ambulatory medicine can be a surprise.
Yes.
You didn't think it was going to be abnormal, and then something comes back.
Yeah, and I talked about this yesterday a little bit, just I don't know who all were there, but essentially I think we're going to have better electronic systems for monitoring to figure out which are the patients falling through the cracks. So if we have better systems where we know that a patient had a fit test, we know they're eligible for a colonoscopy, but they have not had their colonoscopy in whatever, 60 or 90 days, there should be automatic flags that should be sent to a team of people, not necessarily to your in-basket, to a team of people who can then make sure that those patients are not falling through the cracks of the healthcare system.
Great. Well, we are getting close to the end of the hour, and we realize that 9 o'clock people are often heading off to see patients. So I want to just kind of use this time to once again thank Dr. Singh for joining us virtually. Glad the power stayed on. Hopefully the heat's on. Well, I guess the heat doesn't need to be on. It's like 70 degrees.
No, it's 70.
Now.
Yes.
It's all good now. And really kind of giving us ideas about, what kind of things we could be working on. I think all of us are kind of feeling that COVID fatigue. And, it's nice to kind of get a little sort of inspiration to get back to some of the work we were doing before and really think about, like, how can we turn our attention to some of these patient safety issues? What can we do in our practices just with our colleagues, even starting out at a small scale, one-on-one with each other? So lots of great ideas, lots of great resources. So if you want to turn on your videos and applaud Dr. Singh virtually here on mute or whatever.
Oh, thank you. That was very kind.
This is how we do it on Zoom these days.
It's great to be with you all. And I'm going to say one thing before we close. We talked a lot about COVID and COVID taking time away from our usual things. And that, yes, in the short term, it has. But, COVID also needs to be a disruptor in this space, in which case we don't go back to our pre-COVID vulnerabilities. So we actually wrote a paper where we described that, how you flatten the curve, right, for COVID. We said, and some of you might be familiar with Rogers' diffusion of innovations curve, where, there's early adopters and there's laggards, and you try to diffuse innovations over time, over populations. And what we said was, COVID could be the disruptor to accelerate the diffusion of innovations curve. And we should be able to sort of implement some practices much better, because we have worked together against a common enemy now for more than a year. And so when we go back, the common enemy in front of us is all these preventable medical errors, and we just need to get together and work on it. I mean, there has been instances where there's been great communication from the leaders. There has been excellent collaboration between vendors and clinicians and health systems that we've never seen before. When have you seen Google and Apple sort of work together on a few things? Where have you seen the EHR vendors come together and say, hey, we can help you put that, things together. So it could be a great opportunity that we should sort of learn from.
Great. Thanks very much. Thanks everyone for joining us. I'll ask Susan and Dr. Singh to stay on the line with me afterwards. Next
Thank you so much.
month for the Stoeckle Center seminar, Dr. Delicacios and colleagues right there. There she is. She'll be speaking on lifestyle medicine. So we're looking forward to that. So join us in 4 weeks for the next seminar. Thanks everyone.
Thank you.